Hello everyone, my name is Pichamol Jirapinyo. I'd like to thank the SAGES and the organizing committee for the invitation. I'm delighted to give a talk on a few of my favorite procedures entitled Endolumenal Suturing for Primary and Revision. Here are my disclosures. Here's an outline of my talk. We'll first discuss primary procedures, followed by endoscopic revision of bariatric surgeries. ESG or endoscopic sleeve gastroplasty was first performed by Chris Thompson and Rob Haas in India in 2012. The procedure utilizes the overstitch endoscopic suturing device, which was cleared by the FDA in 2008. As shown here, the device is mounted on a double-channel endoscope. At the tip of the scope, you have a curved suture arm and an anchor exchange, which pass a needle and suture back and forth. In 2017, the FDA cleared the single-channel version of the device. On the left is an animation of the prior ESG technique. The video on the right shows our current ESG technique. We start at the distal body on the anterior wall. We then perform a U-stitch pattern, which means we then move down along the greater curvature and the posterior wall. After completing the first arm of the U, we then take the next bite more proximal on the posterior wall and start moving back up to the greater curvature and complete the U at the anterior wall. Here's the final appearance of the sleeve at the end of the procedure. So what are the data like? This paper described a multi-center first-in-man trial from 5 countries. It showed the evolution of the procedure and how the techniques were refined, such as removing the APC lines and recommending using the helix for all the bites. In this study, the procedure was associated with 17% total weight loss at 1 year. Here's one of the key papers on ESG, where Reem Sharaya from Cornell described her initial experience on 91 patients. Since then, several papers have come out describing experience on ESG in Spain, Saudi, Brazil, and India. With more people performing ESG and studying it, the suture pattern has evolved from a triangular pattern to a U pattern. The diagram on the right is similar to what I do now, which is 2 U's in the distal stomach, then 1 interrupted reinforcement stitch medially, and then keep moving up proximally. Here's a meta-analysis from several key players in the field that came out earlier this year. The study included 8 studies with 1,700 patients. At 1 year, patients experienced 16.5% total weight loss. The pooled serious adverse event rate was 2.2%, which included a perigastric leak and fluid collection. In terms of durability, Reem presented her 5-year data at last year's DDW, and we're waiting for her paper to come out hopefully soon. At 5 years, the amount of weight loss was 15.9% total weight loss, and 61% of the patient cohort was able to maintain at least 10% total weight loss. Now we're going to move on to the second primary suturing procedure. POST was first performed by Santiago Horgan in Argentina in 2008. The procedure utilizes the incisionless operating platform, or the IOP placation system. The system was cleared by the FDA in 2010 and consists of 4 components, including the transport, which has 4 working channels, G-profs and G-legs, which are used to grab tissue, and G-cath, which is used to deploy the tissue anchors. Here's the data on a POST procedure from the Essential trial. The study was a multi-center randomized sham-controlled trial, including 332 patients in the US. The efficacy at 1 year was 4.95% total weight loss with a serious adverse event rate of 5%. However, there were some flaws with the study design, and the study actually utilized the old POST technique. Specifically, in the essential trial, the traditional post technique was used, where plications were placed primarily in the fundus. However, over the past 3 years, we have shifted to a new technique called a distal post technique, where plications are placed only in the gastric body, sparing the fundus. Here's a video of our current technique on post. The first plication is placed at the distal body of the stomach and is oriented perpendicular to the length of the stomach to reduce its width, kind of like a belt. We then repeat these plications a few more times. After that, we rotate the G-prox so that it is parallel to the length of the stomach and perform suspender plications to reduce its length. We usually create 2, sometimes 3 rows of suspenders along the greater curvature and also on the posterior wall of the stomach to further shorten the stomach. After that, you rotate the G-prox back and perform proximal belt plications to reduce the width at the proximal body. At the end, you can see that the fundus is left untouched and the stomach is shorter and more narrow. So how's the new technique doing? Here's our experience with distal post. At 6 months, patients experienced 15% total weight loss, with all patients achieving at least 5% total weight loss. At this year's DDW, our colleagues in Spain and at Mayo presented their initial experience on post 2, which is similar to distal post, where plications are placed in the gastric body. They got 17% total weight loss at 6 and 9 months without any serious adverse events. For the second half of the talk, we're going to discuss endoscopic revision for bariatric surgery. The first procedure is TOR, or transoral outlet reduction. This refers to when we use the overstitch device to reduce the size of the outlet. Currently, we use a purse string suture pattern, which means we use 1 suture to place at least 12 stitches around the outlet. As you can see in the video here, we just keep moving counterclockwise until we go around the circle. At the end of the procedure, you cinch the suture around a 7mm balloon to size the final outlet size. We published our experience on this technique a few years ago now on 250 patients. The efficacy at 1 year was 8.4% total weight loss with a serious adverse event rate of 0.8%, which included GI bleeding and GJA stenosis. Regarding suture pattern for TOR, this study demonstrated that purse string suture pattern was superior to interrupted pattern with more weight loss at 1 year. Some of you may have seen a recent paper that came out in GIE earlier this month, showing that APC alone has similar efficacy compared to TOR. However, in this study, a modified figure of 8 pattern was used in the TOR group, which was known to be inferior to the purse string suture pattern. Now, for the past few years, our group has been working on improving the technique to optimize the outcome for TOR. In this paper, we show that instead of doing APC prior to suturing, if you do a modified ESD to expose the muscle layer prior to suturing, you get more weight loss and more durable outcome. Specifically, if you look at the graph here, we matched patients in the APC and ESD group based on their initial GJA and pouch sizes. At 1 year, the ESD group experienced 12% total weight loss compared to 7.5% in the APC group. Furthermore, we also show that adding medications to TOR also gave you more weight loss, up to 15% total weight loss at 1 year. In terms of long-term data, our recent papers show that at 5 years, patients remain at 8.8% total weight loss, with 62% of them maintaining at least 5% total weight loss. Next revision procedure is ROSE, which refers to when we use the IOP placation system to revise the gastric bypass anatomy. We first perform APC around the outlet, just like TOR. We then start placing placations around the outlet to reduce its diameter. After that, we place a few more placations in the pouch to reduce its length. At this year's DDW, we presented our data on this technique on 67 patients. The efficacy at 1 year was 9% total weight loss without any serious adverse events. Now, you might wonder, when should I offer TOR or ROSE? We presented an algorithm for this at this year's presidential plenary. Basically, to be eligible for both TOR and ROSE, you need to have a pouch of at least 5 centimeters due to the length of the IOP. Therefore, I'm going to ignore the diagram on the left here. So once you have a patient with a pouch size of at least 5 centimeters long, you look at the outlet size. If the outlet is smaller than 30 millimeters, ROSE should be considered as it results in greater weight loss. However, if the outlet is larger than 30 millimeters, TOR yields greater weight loss. Last but not least is an endoscopic revision of sleeve gastrectomy. You may revise the sleeve endoscopically using the overstitch. Specifically, you can perform kind of like a mini ESG within the sleeve on the medial side of the suture line. This paper described a combined experience from Brazil and our center showing 18% total weight loss at 1 year with this technique. Alternatively, you can revise the sleeve with the placation system. Here in the video, you can see a relatively dilated sleeve. We then start placating, and we use the pattern that is similar to a distal post pattern. First, we place the placation in the distal body of the sleeve to reduce its width. After that, we place several more placations along the length of the sleeve to shorten the size or the length of the sleeve. At the end, you can see that the sleeve is much tighter. At this year's DDW, we reported our outcome on 18 sleeve patients. At 1 year, patients got 9.8% total weight loss, which was similar to that of the surgical group, but with a shorter length of stay in the hospital. In conclusion, endoluminal suturing appears safe and effective as both primary and revision procedures. These procedures should be performed in a multidisciplinary program in close collaboration with our bariatric surgeon, dietitian, and psychologist colleagues. Data on personalized therapy and combination therapy appear promising, although more studies are warranted. Thank you very much for your attention.